So welcome everyone. It's my pleasure to have our wonderful second part of our postpartum hemorrhage webinar series hosted by the Office of Lifelong Learning and Physician Learning Program at the University of Alberta. My name is Denise Campbell-Sher and I'm the Associate Dean at the office. Our office is committing to providing reliable updates and resources for clinicians, health professionals, and everyone committed to addressing the challenges related to postpartum hemorrhage, which is the leading and most preventable cause of direct maternal mortality and morbidity globally and in Canada. So we would like to acknowledge this afternoon that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. I'd like to start with a little bit of information for the logistics for our session. So if you have any questions about technical challenge or about L3 programs and services, please use the chat feature on the bottom of your screen. If you have questions for the speakers for the Q&A portion of the session, please use the Q&A feature at the bottom of your screen. Please review the questions that have been asked and upvote those questions you'd really like to see answered. We can't guarantee the panelists will be able to respond to all of your questions. A recording of the webinar will be sent via email to all those that registered. Participants can claim CME credits and complete a personal development activity using the My L3 Plan tool. For more information, please scan this QR code, and you can also find this on our Office of Lifelong Learning webpage. This activity has not been formally reviewed by the CFPC or Royal College. However, it is also eligible for non-certified credits. Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise. One of our goals at the Physician Learning Program is to improve delivery of patient care by supporting physicians and teams in data-driven quality improvement and responding to the needs of Albertans as they arise. We would like to invite anyone that's involved in the process of prescribing antimicrobial prophylaxis for obstetrical patients to participate in one of our ongoing projects. So if you'd like to have some more information on this, please scan the QR code. It's a super cool project, so we're hoping we get lots of participants. We're very pleased that today, Dr. Cooper and Dr. Birch will be sharing with us the importance of early recognition and adequate response in management of postpartum hemorrhage, and we'll discuss the role of interprofessional teams in treating this condition. And we're delighted to be joined again by Dr. Stephanie Cooper, who will also be supporting the Q&A. So Dr. Birch undertook his medical training in Newcastle, England, followed by training in general surgery in London, England. He completed residency training in obstetrics and gynecology at Memorial University, Newfoundland. Timmins, Ontario was his home to his OB-GYN practice for 10 years before taking subspecialty training in pelvic reconstructive surgery in 2000-2001 at St. George's Hospital in London, England. And he continues to practice complex high-risk obstetrics at the Foothills Hospital in addition to his urogynecology practice. Dr. Birch was the head of Department of Obstetrics and Gynecology in Calgary from 2018 to 2023 and is the former president of the Western Society of Pelvic Medicine. He's the founder of the Abnormally Invasive Placenta Program in Calgary. And Dr. Thompson is an anesthetist at the Foothills Medical Center, University of Calgary. He's the previous head of obstetrical anesthesia at this institution and has collaborated with Dr. Birch as the anesthesia lead for the development of the Abnormally Invasive Placenta Program and is currently a member of the program. Dr. Cooper requires no introduction. She was introduced last week, so we will jump right to the presentation. So welcome to all of you for participation in our webinar.
Okay, so I'm just going to...
Everyone is going to receive a copy of the recording and Pearl's document afterwards, everyone who registered. Thanks.
Okay, so I'm just going to share my screen. Perfect. Thank you for having me. I'm going to discuss the medical side of the management of severe postpartum hemorrhage. I have no conflicts to declare. So Goals today will be to review the pathophysiology of massive hemorrhage, understand some of the differences with obstetrical patients, and review medications in massive hemorrhage, review some of the blood component use, look at some of the complications that can happen, and develop an approach. So just some of the background, obviously there's a lot of variable definitions, but it's a significant amount of blood loss. And this is one of the leading causes of mortality and morbidity in pregnancy. Its incidence has been increasing in high resource countries. Apnea is the leading cause of postpartum hemorrhage, but when you look at significant massive hemorrhage, accreta tends to be the leading cause of that. And it's quite significant when you think of, in the United States, it's around 11% of all deliveries, and 25% worldwide, the leading cause of death in pregnancy. So when we look at hemostasis, we get a vascular injury and there's a response. We get platelet activation, adhesion, vasoconstriction, secondary activation of the coagulation cascade, thrombin formation and a clot, and then we get fibrinolysis and breakdown of that clot as needed. Now, during pregnancy, hemostasis is quite different. It's teetering on a knife edge of coagulation, and that is likely quite beneficial for the bleeding that patients are going to have when they deliver their baby. But it changes how things are. When you look at fibrinogen levels can be as high as 1,000% greater, or sorry, 2 times greater, and factor 7 can be 1,000 times greater. Protein C has resistance, protein S activity goes down, TPA activity is decreased because of TPA activator inhibitor levels rise. And when you look at TPA2 is only shown in pregnancy. So there's a very procoagulant tip as a beneficial reaction for pregnant patients. Now this can affect how we treat them because normal lab work, a PT and PTT in a massive hemorrhage may mean that they're still coagulopathic. In a massive transfusion, it changes as well. If we're not careful with how we respond to a massive transfusion and give too much colloid or crystalloid, we can cause dilution of coagulation factors, anemia, acidosis, hypothermia. This can be compounded by a cold patient, creating more acidosis, tissue hypoxia, and this all feeds back to more bleeding and coagulopathy. So when we look at obstetrical hemorrhage, there's 4 R's that we need to think of. There was a working group in the States that was put together to decrease morbidity and mortality that was preventable in obstetrical patients. And we need to think about readiness, recognition, response, and reporting. So readiness. Prediction is inherently difficult, but there certainly are risk factors. And these can be pregnancy or maternally related. We need to think about if our site has the resources to deal with aggressive bleeding and whether or not those patients should be transferred. And that can be, do we need to do damage control and transfer them out where it's still possible? Do we transfer them before things happen? Or are we capable of doing it? And do we have the proper setup? Do we have large enough IV access? Do we have a cell saver perhaps? Do we have level 1s, warming devices, etc.? So self-salvage is one thing that we need to consider when we're going into a case where there might be a lot of bleeding. And it should be considered when you're expecting greater than 20% blood volume loss. The reason for this is you do need quite a bit of blood in order to give blood back. It makes a lot of sense in patients that won't accept blood products, like a Jehovah's Witness, if they're willing to accept self-salvage blood. You need a team that's able to use this, so you do need to use it frequently, but it is safe. We use leukocyte reduction filters now. However, that really delays the time in getting blood back because it takes a while to go through that filter. Maternal fetal allo immunization can be an issue, but it can be treated. The Salvo trial out of Europe in the early 2010s showed that it's cost effective and safe and should be considered in these cases where there is anticipated large amounts of bleeding. So you can never forget what the cause of the bleeding is and to not get fixated. Tone happens to be the most common cause, but you do have to keep thinking about why is this patient bleeding and actively looking to treat those causes quickly. Recognition. Early recognition is very important and should be started within the first 30 minutes. Communication is key. This is not a solitary endeavor. There's a lot of resources that need to be used when you've gone down the path of a massive hemorrhage. The blood bank needs to be notified so that they can put resources towards preparing blood products, anticipating your needs coming up. The operating room may need to know to anticipate and get things ready. More nurses need to come in to help draw up drugs, get products ready, prepare the patient, get other resources that are needed, etc. So it's important to communicate. Restrictive resuscitation happening right away is important, although we do want to limit how much crystalloid we give a patient because that can affect their morbidity and mortality if we over-resuscitate with crystalloid before blood products arrive. Blood products have to be transfused right away in a massive transfusion. You cannot wait for lab results to come back. These are going to come back later and serially, but you need to give blood products before you have any information back. Permissive hypotension is a very reasonable approach when you're actively resuscitating a patient with a MAP of 55 to 60. There's no vasopressor that's been shown to be superior than others. However, it is reasonable to use that and should be used to target slight permissive hypotension. Assessing blood loss can be difficult. Our visual ability is quite poor. We're often off by 30 to 50%, but it's helpful to have visual aids and charts that allow people in the room or area to get an idea of how much bleeding there is. Now, remember, this is going to be a guesstimate. The other thing that has to happen while this is going on is measuring sponges, blood that's coming off as much as possible to have a quantitative blood loss. Now, again, this isn't going to be completely accurate, but it's better than having nothing. And this needs to have an ongoing assessment to give you a better idea of how much blood loss is ongoing. Clinical assessment is very important because there can be a lot of hidden bleeding, retroperitoneally within the uterus itself. Because of the increased circulating volume, a lot of volume loss is very well tolerated before vital signs will change in a pregnant patient, especially younger ones. So when they do have a drop in blood pressure, it's a significant amount of blood loss has happened. And it's important to have ongoing clinical assessment to the response to your fluid resuscitation. A helpful aid is the shock index, which looks at heart rate divided by the systolic blood pressure. And if your shock index is greater than 1 and approaching 1.5, the patient has lost a lot of blood and a massive transfusion protocol should be activated. There's other aids like a critical transfusion threshold and a resuscitation index that can be looked at, which look at how many products over a period of time have been given. Uterotonics are always important. Atony is a leading cause, so active management of the third stage of labor will help prevent a lot. The best postpartum hemorrhage is the one that doesn't happen. The second best is the one that you respond to appropriately. Second line agents need to be used, and they need to be used aggressively if you're worried about atony. We tend to use ergot at our site just due to the side effect profile, and its onset is quite quick. There were some concerns in the United States about adverse effects. However, if given intramuscularly, it's quite a safe and effective drug to be given. It's 0.2 milligrams IM and can be given every 2 to 4 hours if there's no contraindications like hypertensive disease or cardiac ischemia. Hemabate or carboprost is another drug that we use as well as a second line agent that can be given every 15 minutes. Usually takes a couple of doses to take effect, and it's 250 mics intrauterine or intramuscular. Will work the same, less side effects intrauterine. However, both methods are fine, and it can be quite effective. However, it should not be given to asthmatics with the risk of bronchospasm. And as well, it has a lot of GI effects, is why we give ergot first. So tranexamic acid works by reducing clot breakdown, and this should be given to all pregnant patients that are bleeding. It has been shown to be safe. Early research in trauma, like the CRASH 2 trial, showed that it significantly reduced death due to bleeding if given early in a trauma. This was subsequently shown in perioperative surgical patients in the POISE 3 trial, where again, significantly reduced death due to bleeding. There continued to be safety concerns over venous thromboembolism in pregnant patients. However, the woman trial came out. It was a multi-country, multi-center trial looking at over 20,000 patients. That showed there was no increased adverse effects, and it was effective and significantly reduced death due to bleeding in postpartum hemorrhage. So this should be given early. It's a gram over a couple minutes, and can be redosed within 30 minutes if there is no response. However, it should not be given if it's been more than 3 hours since the bleeding's commenced, as this can actually increase mortality and morbidity, and that's been shown in the trauma literature as well. It should be given preventatively as well, if there is concern of bleeding. So ratios are what we start with when we're in a massive hemorrhage and we don't have any lab work back. This is because the resuscitation needs to start immediately in massive bleeding. We can't wait for the lab work to be back. And the origination of this was a military setting where whole blood with the walking wounded blood bank was originated. There's been several studies in trauma that have validated this. The PROM-T trial was the first one that showed a benefit of giving 1-to-1 red cells to plasma. The proper trial came later and showed that there was no benefit of 1-to-1 versus 1-to-2, but these ratios were important. Unfortunately, there's been no finished good trials, and there is some ongoing trials currently looking at ratios, but this hasn't been determined. The European guidelines suggest 2-to-1 red cells to plasma and platelets, but to avoid in more minor hemorrhages, this is unnecessary. Now, one thing to consider in this is not the trick trial. The goal is higher in a bleeding patient because of the rheologic effects of having enough hemoglobin around for platelet activation to help platelets migrate to the periphery, so that we can get better clotting. In animal models, giving a red blood cell transfusion to thrombocytopenic animals helps clotting. And that makes sense with how the clotting cascade works. Without enough red blood cells, it's hard to clot. So most guidelines suggest keeping a hemoglobin of greater than 85. But as you can anticipate, because you're getting serial blood work back and looking at it in a retrospective nature, if you're waiting for that number, you're going to be far lower than that. So the goal should be over 100, and to maintain that for proper clotting. Fibrinogen is very important in pregnant patients. Early correction is very important. Dropping below 2 grams per liter has a 100% predictive value of major hemorrhage and significant morbidity and mortality in a pregnant patient. Our MTP kits come with Riastap 4 grams with the first box of blood, and that should be given. It's quite difficult to mix up again, where help comes into hand, is it has to be slowly mixed together. Otherwise it foams up and takes forever to be given. So you got to be quite careful with that and have somebody who knows what they're doing mixing it together. You need about 60 milligrams per kilo to increase 1 gram per liter. And again, remember, our goals are higher in a pregnant patient than they are in the non-pregnant patient, and should be kept above 2 according to most guidelines. Even if the PT and PTT is normal and you do have that blood work, they should still be given fibrinogen during their resuscitation. Platelets. This is a bit of a different beast, as you can bring patients from bone marrow stores and the liver. So people tend to not drop their platelet count unless they've lost a couple of blood volumes. They'll get down to about 50 if they start with a normal platelet count. Obviously, keeping in mind patients that have HELP syndrome or ITP will obviously be in a different boat than this. But the goal is to maintain above 50. You don't need platelets of 100 to have clotting, but you do need a reasonable platelet count. Now, during active bleeding, again, this is obviously going to have to be higher because your blood work is serial and is going to be coming in later. So if you're using too low of a transfusion trigger, it's going to be far lower than that by the time you give products. Got to be careful giving platelets. They can't be used with a microaggregation filter. You're going to remove most of them. It shouldn't be warmed because there's concern with activation. Definitely shouldn't be under pressure, or you will activate the platelets and it won't be as effective with their transfusion. And ABO compatible is better because you'll have more active platelets to help with clotting. Coagulation factors should be replaced immediately as well. we do get FFP in a 2-to-1 ratio in our first box, and will come with the subsequent boxes. Again, if you have no lab results, you should be given 15 mils per kilo of FFP, and the goal should be to maintain a PTT within greater than or equal to 1.5 times normal. This would go against some of the non-obstetrical literature, which suggests 1.8. However, in pregnancy, a greater number shows greater coagulopathy, and this is a different beast of patient than your non-pregnant patient. Also remember that you're not going to have much thawed FFP, so this is where the communication piece comes in, as you need to be speaking with the blood bank, so this gets thawed quickly so it's able to be used. Prothrombin complex concentrate is currently recommended against, unless you're looking at a Hail Mary. The reason for this is the risk of thrombotic events. Could be considered in patients with severe liver disease or clotting deficient disorders that are either inherited or acquired. Typically, patients who are pregnant aren't on warfarin given the teratogenicity effects. However, HELLP syndrome patients may be somebody that could benefit from this given certain contexts, but in all comers, this is not recommended. The other place where this could be considered is giving in a rural setting with fibrinogen if you're awaiting transport to try and stem some of the bleeding if you're not able to have enough blood products on hand, and more as a Hail Mary rescue. There are some current ongoing studies that may change that recommendation, but those are currently being done. Recombinant factor 7A showed a lot of early promise in case reports. However, when it was studied, it decreased blood product usage but didn't change mortality. And there were significant adverse effects such as arterial thrombosis. So again, it's currently not recommended unless it's part of a clinical trial or as a Hail Mary attempt. The activated pharmacologic dose causes a thrombin burst off of the platelets and creates a much more intense platelet plug and activation of thrombin generation. But this tends to cause some adverse events. So again, just to be used in a Hail Mary, and this would more be a bleeding patient. Things to consider with recombinant factor 7A if you are going to use it is the patient needs to have a good platelet count. They can't be cold. Their acidosis has to be corrected, and their fibrinogen levels have to be corrected just based on its mechanism of action, or it'll be ineffective. So once we get underway, we need to begin goal-directed therapy. You need ongoing assessment with blood work. This is where an arterial line will be helpful in ongoing bleeding, as you can draw blood work, get a hemoglobin back much quicker, but you're going to be sending CBCs, INR, PTT, electrolyte levels, and then you can measure your lactate and base level to see how well you're resuscitating the patient if you do have an arterial line in place. If you do have point-of-care devices such as TEG or ROTEM, it's great looking at clot speed and quality, and this can give you a much more expedient idea of whether you need to transfuse platelets, fibrinogen, or coagulation factors. However, most obstetrical units don't have TEG or ROTEM availability in Canada. And again, continue to monitor quantitative blood loss and stay up with that and monitor the patient clinically. Hypocalcemia is quite common. You can expect to have to give about a gram every 4 units of packed red cells, probably a little more if you're giving FFP and platelets, as the citrate binds calcium and removes it. And this is quite an issue because it'll affect your clotting, affect cardiac function if you don't replace it properly. Hyperkalemia can also be an issue. As blood is stored, it ages and releases potassium and can be quite high. In some stored blood, it can be as high as 30 millimoles per liter. And in a small patient, cold blood is the same as giving cardioplegia if they're small enough. So you do have to have an idea that you have to keep track of their potassium level. It's also why it's important to keep a normal calcium level for membrane stabilization and cardiac myocytes, so you don't encourage arrhythmias. Now, acidosis will make this worse, so that's also why it's important to make sure the patient doesn't become too acidotic while you're resuscitating them. Most patients will not have an issue with this. However, patients with liver disease, because that's where citrate is metabolized, will have an increased risk. And obviously, renal failure patients that are starting with a higher potassium level and don't have the ability to clear it as efficiently will have issues. Temperature is important as hypothermia causes significant coagulopathy, and this is progressive. So it is important to actively rewarm and warm the patient with external devices and approved fluid warming devices while you're giving blood products, as packed red blood cells are quite cold as they're coming from the fridge, and plasma has just been thawed. So obviously this will drop somebody's temperature significantly if it isn't warmed. Acidosis can also affect clotting in a progressive fashion and needs to be closely monitored. Usually this doesn't need to be replaced with bicarb. However, it should be considered if somebody's pH drops below 7.2, because this will start to significantly affect coagulation. It also affects some of the drugs. As I alluded to earlier, activated factor 7 doesn't work very well if somebody's acidotic, but fortunately it doesn't affect the activity of tranexamic acid. Basics: oxygen and hemodynamics are important. Maintaining a MAP with permissive hypotension during your resuscitation is important. And again, it doesn't matter which vasopressor you use, but you likely will need some vasopressor to maintain reasonable perfusion pressures. But these don't have to be super high, as you don't want to exaggerate any of the bleeding, as you don't want to be too aggressive with that. Also, providing supplemental oxygen is important. As patients become extremely anemic, the dissolved oxygen in blood becomes important. However, this is more of an extreme example. However, early intubation should be considered in a massive transfusion given fluid shifts and the risk of transfusion-associated lung injury and transfusion overload. So every major site that is dealing with this potential should have a massive transfusion protocol, and it needs a process for activating it and also deactivating it so that resources can be used appropriately. Communication between the patient area and the blood bank is extremely important as early as possible, and also letting them know when you don't need them anymore. It takes a lot of resources to run a massive transfusion in the blood bank as well as in your treatment area. Consistent blood component packs so you know what you're getting, so that you know what to order on top of what you should be getting. Disposition of unused products. You don't want to be wasting a whole bunch of blood products. Active adjunct therapies with medicines, so treating atony properly, calcium, making sure their potassium is okay. Consistent and timely lab results. You need to keep checking how you're doing and looking back at how you're doing, because it's going to be coming 20 to 30 minutes after you've given the lab the results. They've got to run them and get the results back to you. So you're going to be looking in a timely fashion how your treatment has been going. And ongoing audits. You got to make sure you're treating these patients appropriately, and what can we fix? What do we do right? What do we do wrong? It's good to have a checklist in the operating room, visual aids, give people an idea of what to run through in their protocol once this process happens, so that nothing is forgotten, and allows a much more tight, better treatment of the patient and an optimal treatment so that they get everything done that they need. So key points today for my part are: early aggressive treatment is extremely important before things get out of hand. This is a multidisciplinary event. Bring friends to the table. You're going to need a lot of help mixing, checking blood, etc. There's a lot of things that need to happen. Start with low ratio blood component therapy to begin with, but quickly move to goal-directed therapy as soon as possible. Maintain normal physiology as best as you can. Everything in the human body works better in a tight range, as does clotting. Preparation, training, and review are required, as these are intense events, and without proper training and preparation, it can easily get out of hand and have bad outcomes. And it just, the review allows you to just tighten your process and have better treatment of these patients. So that's where I'm going to stop and hand over to Dr. Birch.
Well, he's doing that. Rob, you just mentioned about staying warm, and I think that's a really important area that lots of people can easily do, the importance of using warming blankets, and that the solutions and blood products that you give are warmed when appropriate as well.
Hi, my name is Colin Birch. Thank you for the introduction. Thank you for the invite. Sadly, no disclosures. And I'm going to talk about management of intractable or severe postpartum hemorrhage. And essentially, when we get to the surgical side of things, the you-know-what has certainly hit the fan. So I'm going to just give some sort of points about approaching this, because if you think about it very carefully, you have the risk of having to do something surgical for postpartum hemorrhage can occur basically anywhere where someone does a delivery, and where you have some surgical type of, wherever you do obstetrical deliveries, you always run the risk of having to end up with doing something surgical. When it gets to something surgical, things are really quite dire. And obviously, you know, as Rob alludes to, you know, here we are at level 3, we have blood immediately ready for us, massive transfusion packs, labs that come back reasonably quickly, a ton of staff. And so, you know, we're very lucky. Granted, we do more deliveries and therefore more likely to see it. But unfortunately, it's going to occur in a place that's 300 deliveries, and that's cesarean section capabilities and OR capabilities. So it has to bear that in mind. Love quotes, and this is absolutely perfect for postpartum hemorrhage. You should, if you are at a point after medical management where things are not basically resolving, it's dangerous to defer or take yourself away from a surgical intervention. Where people die, look at the triennial reports from Britain, they die from delay more often than not. A delay to do something, firstly, primarily what Rob and Stephanie would do, but secondarily, the delay to do something surgical. And so you have to get over that idea. The patient has to be maintained alive, and you have to cut your cloth as to where you work, because it's different for me here than it would be in a level 3 center or level 1 center, I beg your pardon. I always see postpartum hemorrhage a bit like this, and we've viewed this in the past very much like this. Patients have preloaded themselves, and so as a result of that, they tolerate postpartum hemorrhage, and we all think we're doing a good job. And of course, now with Stephanie, with our estimated blood loss being done, we tend to avoid this, but I think it still happens, whereby patients fall off a cliff, and by the time they've fallen off a cliff, not only are they hemodynamically unstable, they're obviously into realms of coagulopathy. It's really important with postpartum hemorrhage to have communication between the OBs or whoever's delivering the baby, midwives or whoever, the nursing staff, anesthesia staff, and OB/surgical staff. And it's even more important when you're looking at surgical intervention, because things have really got down and dire, and you're down to the wire from that point of view. When going for surgical interventions, really, it oftentimes flexes around hemodynamics and coagulopathy. Now, of course, coagulopathy is hard to determine if you're in a level 1 center and don't have ready access to blood clotting, blood work, and your lab staff are out of the hospital. But it's usually pretty obvious that if a patient's not clotting, it's basically runny blood coming out of everywhere, bleeding from the IV site. So it's a very rough idea. If you're in that situation, at that point in time, you need to be, whilst maintaining coagulation such as Rob's described, you need to be moving this patient to a high acuity operating area. When you're considering that, and this has to be considered very quickly, this is not something where you can sit around and navel gaze for half an hour. It's basically, you've got to think, well, what have I done, and how have I trained to be able to deal with this surgically? If you're the actual operator, do I have a skilled assistant around of any sort? Not just somebody who can hold a retractor, though that's better than nothing. What's the skill set of anesthesia? This is where this communication plays in a huge way. The skill set of nursing staff, in some places you may be venturing into an area where people have never seen it before, and never seen the severity of postpartum hemorrhage, and also the fact that it needs surgery. But the other thing you've got to think about is we can glibly say we can get a massive transfusion pack and we send the nurses upstairs and they come down with a big box like Christmas and we're all very well and good. However, in a smaller place, you may be limited by the amount of blood you've got, be it O negative or any type specific. And again, you maybe have your lab staff way out of the hospital and half an hour or more away from the hospital itself. So all those things need to be, I think, factored in as you make this decision, which is a dramatic decision, first of all, to go to the operating room. And then what is the supports around you for that? I think if there's time, you need to call a friend. And basically, if you're in a level 1, maybe a level 2, but level 1 especially, and you're getting into this kind of scenario, you need to have some communication with level 2 or level 3 colleagues. Basically, you can talk this through. It's going to be very quick. You need to talk it through and basically come up with a plan. The plan is either going, I'm going to go ahead with you on my shoulder helping me. 2, are we activating transport, thinking, can we gather enough? Do we have enough blood products to maintain this patient in a transit to a hospital that has more blood work and more blood available, but also surgery available as well? So that conversation, this communication needs to be open very quickly, because you do not need to be doing this in isolation if you've never done this before, never taken the patient to the operating room for an invasive surgical procedure for postpartum hemorrhage. Consent process. The bottom line behind this is, if you're taking a vaginal delivery to the operating room because of hemorrhage, that patient needs to be fully aware that hysterectomy is on the cards. And that needs to be said. If it's not consented, and I can understand why, because you're in a hurry and everything else, it needs to be documented that this conversation has been had. So what are the clinical scenarios that you might get into which might force you to the operating room? Really, I've gone through a few here, but the ones you may come into commonly, and certainly outside of the tertiary care, so obviously an anticipated abnormal invasive placenta you're not going to be keeping. The commonest one, of course, is an intractable postpartum hemorrhage post-vaginal delivery, which is hemodynamically unstable, and your suspicion that you're having a coagulopathy, or you've proven they've got a coagulopathy. So with ongoing bleeding, you're moving to the operating room. You trying to atony after cesarean section, prolonged labor, that can happen anywhere. And again, that is somewhere where you can very much run into massive bleeding very quickly in that atonic uterus. And the other one is the unanticipated abnormal invasive placenta, though realistically speaking, that should have been selected out before you get to this point. So again, you go into the operating room after vaginal delivery, when medical measures and Bakri have not worked, you're moving to the operating room with the sole intent of doing hysterectomy. If you decide to do something different in the meanwhile, that's good and that's fine. We're going to talk about that. But you're going there to do hysterectomy. So in your operating room, you've got to have some setup for this. And obviously, hysterectomy set needs to be available. If you're going with this in this situation, you need a few things in preparation. And these are ones I like if I'm into this. I like a 3-way Foley catheter. And the reasons I like that is, 1, and I irrigate the bladder. 2, I can put fluid in it to check that I haven't put a hole in the bladder. And thirdly, you can irrigate the bladder if you've injured it and you've got hematuria. Patient needs to be in dorsal lithotomy position. It needs to be low. You need to have the stirrups. The reason for that is you need to have an under buttock grape, as been described by Stephanie, where you can measure ongoing blood loss. To have them lying flat with the legs together, you can lose a whole lot of blood down the bottom of the table and have no idea it's going on. And the anaesthetist who will be saying to you, hey, Colin, this patient's blood pressure is 40 systolic. And I'm saying, well, it looks kind of dry where I am. And that's because I'm not aware of what's going on below. Decent retractor long instruments. You need to have on stock suture material for compression. And obviously blood products. So if you get in this situation, again, this is the conversation you need to have. You need to have it with a lab, who may not be on site in a smaller center. And you also need to know what's available. And this is where the conversation, I think, with someone in a larger center, if you're in level 1, or level 2, one, can you transfer the patient out? And that's a really hard decision to make, and it's a terrible decision to have to make. Or can you bring somebody in? Equally difficult. In an ideal world, cystoscopy, the important thing is having people. Now, you can have too many people in the operating room, and we've all been there where it runs around. It's a bit like Keystone Cops. Everybody's running into each other, no designated tasks. So this needs to be sort of simulated, so people know what their tasks are. So there's a runner for the anaesthetist, for Rob, for instance. There's a runner for the surgical team. So adequate number of people, great. Too many because they want to help out. It's like Keystone Cops. People are bumping each other all over the place and really unhelpful. So what are your options? Well, I've talked about hysterectomy, and I'll talk some more about it. But the essential part is this. If you're taking a patient to the operating room for an intractable postpartum hemorrhage, where it's due to atony or placental bed bleeding in the absence of placenta previa, who wouldn't have had a vaginal delivery anyway, then you can hardly get away with a subtotal hysterectomy. And I'm not saying that's easy to do, but it's relatively easy to do because for the most part, the ureter and the bladder do not come into play. You can do sequential vessel ligation, which I'll talk about. Choice squares are sort of half and half compression suture and partly vascular ligation. There's all types of compression sutures, which I'll talk about. Internal iliac ligation. Now, you go to meetings and people stand up and say, oh, well, we should do an internal iliac ligation. Unless you're familiar with this, unless you're familiar with the way of performing that, recognize it might decrease your pulse pressure for 20 minutes. I'm not exactly convinced that that's a fair trade-off if you don't know where you're going. Aortic compression is one of them. And I can remember the first time I did a hysterectomy postpartum, and I was in a small place, no assists, and we just happened to have a thoracic surgeon going past, and he basically came in and put aortic pressure for me. There's a Rabo, and this is more just for interest as opposed to anything else. It was just a endovascular balloon occlusion of the aorta, and it's basically like a massive balloon that goes in the aorta, and that's more for interest value than it is for whether in fact you're going to have that in your site, which you're not going to. And basically the other thing you can do is pack. Packing is always an option, especially if you're thinking about transportation. So sequential vessel occlusion. In the current age of cesarean section, and this is where we're talking about cesarean section at this point in time, and this can be true if you're brave enough to want to do sequential vessel occlusion in somebody without a hysterectomy scar. Pretty brave. That's the reason why you have the patient lithotomy, to see what's coming out per vaginum. If you mark where the cesarean section scar normally would be, the uterine artery is coming usually below that. The days when we used to dissect the bladder way down and therefore we're below the insertion, ligating it as it ascends. Here you can see the dotted lines. You can do the uterine artery. Now, various different people talk about different techniques for this. I don't tend to use a bigger needle than a CT1 for this, and I snug it into the actual body of the uterus as well, because if you don't snug it in the body of the uterus, branches such as the vaginal branch will get torn and you'll actually exacerbate the bleeding and exacerbate the bleeding further down. I will actually put a suture above the level of where the hysterectomy scar either is or where it would be. And then you're going to go high in the uterovarian. And again, the blood supply, if you've ever done tubal ligation, you'll know, again, it comes through an arcade, which comes off the infundibulopelvic ligament, and it comes down, it runs on top of the uterine ovarian ligament. So ligating the uterovarian ligament, you're not going to cause ischemia in the ovary, but you are going to decrease that secondary blood supply to the uterus, which comes down through the uterovarian, which basically anastomoses with the ascending branches of the uterine artery. You can do this in combination with something called choice squares. Now, choice squares are okay. I'm not a huge fan of them. Where I think they have a place is in a situation where you feel that there is bleeding from placental site. And if you've got that, you generally got hysterotomy scar, aka cesarean section scar. I don't think they work that well when you're using them for an atonic uterus. I think it looks like a nice quilt at the end of the time, but I actually don't think it makes a great deal of difference. And so I'm not a huge fan, apart from that situation I've described. This is internal iliac ligation, and you know, if only it was so simple as this. Just for educational value, to do it quickly, it's basically through an avascular space between the infundibulopelvic ligament and the round ligament. You shoot down to psoas, you run over the top of the common iliac and the external iliac, find the ureter medially, it's on the medial fold, and then about 3 to 4 centimeters down the internal iliac, you'll put a clip on it. The old way is to put a Leahy around it and go from lateral to medial. The jeopardy of that is catching the internal iliac vein, and that will bleed a lot. So that's your anatomical relations. And if you know, it needs to be practiced, and it needs to be practiced, and it needs to be practiced. And if you haven't practiced it, this is not the route you should be going from a point of view of managing postpartum hemorrhage, because you can cause more hemorrhage by doing this if you really don't know. And worse still, this is a case I've seen, is you can find the external iliac artery and you can give them a blue leg, which is ischemic, and if it's on there for long enough, can decrease the function of that leg permanently. That's just a word to the wise from a point of view of, you know, going down for the internal iliac artery. Then you can get the aorta, and this is just for informational. The left pictures really show this reboa, which is just a big balloon you put beneath the level of renals. The picture on the right is to say you get your arm strength and you push on the aorta. And again, there's massive collateral vessels to the uterus. So again, even pushing on the aorta with all the issues, it might give you 20 minutes of decreased pulse pressure again as the collaterals open themselves up. But maybe the difference, you don't have to be terribly skilled to do it. You just have to find the bifurcation and go above the bifurcation. You know, okay, desperate times, desperate measures, as it were. So compression sutures, you can do it in 2 ways. You can do it if there's been a vaginal delivery, you think there's an atonic uterus, it's not responding to anything you've done up to including all the uterotonics plus the Bacri. And so you can take them to the operating room, but you need, as I've said, lithotomy position and a bag at the bottom of the bed to make sure you know how much blood you're losing. Or you can do it in a situation where there's a hysterotomy scar, which of course are much more described, as you all know, and I'll come on to talk about that. When you're doing compression sutures, there's the jeopardy of having suture material going into the uterine cavity. You need to keep, or if you're doing this, you need to keep an ongoing check on what your blood loss is. So someone needs to be watching this, and it needs to be measured accurately. You can't rely on anaesthetist telling you that they're hypotensive. To Dr. Thompson's point, you need to be proactive, not reactive, as much as you can in this situation. And simple as this, if you don't wait a long time to see if your compression sutures and or vessel ligation's working before you move forward to hysterectomy. So these are some of the type. This is the sort of typical B-Lynch suture. I'm not a big fan of this, I must be honest with you. The classic B-Lynch suture was described where the suture comes up and over. It's like a brace sort, a belt and brace kind of affair. I don't like it for 2 reasons. One, it's a continuous suture, so it's very difficult to get, I find, get the total compression down of both sides of the uterus fundus. If it's not at least sutured to the top of the fundus, those sutures will slip off. And I think that's problematic from a point of view of intraoperative problems and postoperative problems. These are the alternatives you can see. Now, the one on the left-hand side of the picture is the Lynch, and the one on the right is an alternative version, which you can actually get away with. And there's several of these types of sutures where you don't actually have to have a hysterotomy scar. You can have if you want to, whereby you'll put a suture, which is basically a loop suture. So basically, you're going above the level of the cervix, through the lower segment, and looping the suture around. You've certainly got to have intestinal fortitude if you've got significant hemorrhage in the operating room to basically do this technique. And there'll be people who say, I did that technique and it worked fine, and maybe the tincture of time has helped them. But I think you have to have quite intestinal fortitude to do a fertility sparing procedure in that scenario. We published this, and this is the technique I use for compression sutures. We published it about 10 years ago, ironically, a urogynecologist and a gynecologist. However, the way it's different is two separate sutures. The hysterotomy scar is left open. It's anchored at the top where point C is. So there's an anchoring of it as well. So it's not going to slip off. It's not going to cause problems by doing so. And actually, you get a good compression because you're doing each side individually. And it's a procedure that can be done 5 minutes, literally 5 minutes. This is a newer one that's been described. Again, I don't need to go into it. Basically, they don't enter the uterine cavity with this, or they don't think they enter the uterine cavity if they've got no hysterotomy scar. Again, it's just a suture that goes back to front and then comes back over again. I think the compression sutures are really more or less the same. They're more a version of the B-Lynch suture, which is probably the traditional and probably the most standard of the suture techniques. Those are two sutures that you need to have on hand if you are doing a compression suture. The ideal suture would, of course, be using something such as PDS, though, because it's monofilament, it runs very easily. Chromic sort of comes close, as it were, to that. But again, you need a bigger needle. And I've often used the Viper because the technique I use is two sutures. And this suture works really well because of the size of the needle. And the Viper is actually what I use these days, because I'm using individual sutures side on side as opposed to one running suture, which won't pull through if you're using Vicryl. And compression sutures don't come without implication. The first, of course, if it's a suture material which is transecting the uterine cavity, so the risk of intrauterine adhesions, Asherman syndrome, real and subsequent infertility. If you have a compression suture that compresses the lower uterine segment, you can run into hematometria and pyometria. There have been case reports of uterine necrosis where you've actually done too good a job, i.e. you've devascularized the uterus so much that part of it falls off. And they usually present or have presented in the case reports with obviously pain, significant pain, evidence of bleeding, a white count sepsis, and a required hysterectomy. Long-term risks, uterine rupture during a subsequent pregnancy because of decreased vascularity. And there have been case reports of bowel obstruction with loose suture. And that's the reason why I don't like the original B-Lynch suture, which is not sutured through the fundus of the uterus and doesn't sort of hold it at the fundus. Again, suture material, that's what I use. You can use whatever material you want to use. Everything's got jeopardy if it comes through the uterine cavity, but you're trying to stop bleeding basically. And in those situations where you're using compression sutures, you're trying to stop bleeding to maintain fertility or the potential for fertility. Sometimes it just goes south, and this is one of those home pictures that you take of a bad day at the office. So, you know, you're doing your hysterectomy, all your other stuff has failed. There's no need to be brave. If you're doing hysterectomy for atony or placental bed bleeding, you do not need to do a total hysterectomy. You do not. It's a clamp and drop technique. Clamp it, take a deep breath, because once you've clamped the uterovarians and you've clamped the uterines, your bleeding for the most part has ceased. And then you can sort of think about everything else. A total hysterectomy needs bladder mobilization, the ureters become at jeopardy, bladder injury becomes at jeopardy. So, I mean, there's much more involved in this. So I think that what I'm saying is that in 99% of the time, you're taking somebody back from a vaginal delivery for postpartum hemorrhage to the operating room where you're undertaking hysterectomy. You can do a subtotal hysterectomy and get the bleeding stopped probably in 10 minutes and even less, depending upon how well you've perhaps simulated this. Incisions I make, again, post-vaginal delivery, I would do a fan and steel incision. I'm not a big fan of subarumbilical incisions, apart from some of the AIP cases we do. And obviously the supraumbilical is for patients who are prepared for the winter. A bit on bladder injury, and I'm not going to go into light details. We're getting to the end of this, but essentially recognize it. You've got a three-way catheter in situ. If there's any doubt in your mind, methylene blue solution, you place it up through the catheter into the bladder and see if there's a leak. If there's a leak, you can repair it, 3-layer repair. Best to do it with things like, I mean, you can use whatever you like, really, but monocryl and PDS are the sutures you should be using for this. Sometimes things just don't get that better. You slow it down, you've done your hysterectomy, you've slowed it down. That's time to get on the phone again to your friend and ask them what they're going to do right now. Perhaps in a bigger center, you might get uterine artery embolization or embolization, but that's not readily available, certainly in smaller centers. So what's your friend? Your friend is packing the abdomen. I've done it. I think it gets, sometimes you get to the point where you've got ongoing coagulopathy, ongoing blood loss. It's not massive, but it's enough. Oftentimes you may not have embolization readily available to you. Pack them, pack them, pack them. Close fascia interrupted, put a vac dressing or cling dressing. And if you're in a smaller place, get the patient out. That's the reason why there needs to be ongoing communication with your friends at the larger center, because if you get bleeding post-hysterectomy in a smaller place, then you're hooped, and you don't want to be starting the conversation with transportation at that point in time. You want to have the conversation already open before you actually start your procedure that you're doing. And then oftentimes I'll put them in ICU and bring them back the next day. And the two occasions I've had to do this in a few years of practice, both patients came back the next day and they were dry, because it given us the opportunity to reverse the coagulopathy, help the hemoglobin, do all the things that Rob has spoken about already. And STARS is your friend. Simulation, just to finish this off at the end here, is so important. And people say, well, it's not going to happen where I am. It's going to happen anywhere that you're doing vaginal deliveries, and if it's OR, there is a risk that you're going to end up going there for a postpartum hemorrhage and doing hysterectomy. So always debrief. If you have something like this, debrief and learn from it. So you debrief, learn, simulate, so that the next time it happens 10 years later, at least there's some fragments of what we did before and you have some preparation for it. One last plug. If you happen to be doing a book cesarean section and you've come across something like this, I would suggest wholly that you close the abdomen and send them to somebody who's happier dealing with abnormal invasive placenta. Because as you can see from this is a real cause, a cause for hysterectomy to be done. There's no compression sutures going here. Just close and send it along. So with that, we're at 1 o'clock. Sorry I took so long. Happy to answer any questions anybody might have. This is a very interesting place. I worked overseas, and Ward 10 was specifically very interesting because it was full every morning when I came to work.
Oh my goodness. Well, thank you so much to both Dr. Birch and Dr. Thompson. I know we are at the hour for clinic, but if people have questions, I think people have just been listening, but does anyone have a question that you want to ask? And you will receive a copy of the presentation, as well as a Pearls document from the presenters. They're working to curate resources for you. Please take a second to give some feedback. And feel free to forward questions if you're shy, and we can pass them on to the speakers as well. But don't be shy. The whole point of this is to learn and debrief, as Dr. Birch just said.
Yeah, and this is just Stephanie, just to follow up. A lot of this, a lot of people here are probably not the people who are going to be doing these techniques, including myself, and definitely not the internal iliac artery ligation ever. But, knowing and sort of an idea of what these procedures are and being able to then do multidisciplinary drills and simulations is so important, because that's where you learn. And just, the example, as Rob said, how to mix up rheostat, or if Dr. Birch is talking about a certain type of procedure, knowing what the sutures are, some of those little things that every team member has such an important part in helping for the care of these patients. So using all this background information and then going forward and actually having multidisciplinary simulations of, postpartum hemorrhage that becomes very severe.
No, fantastic. Steph, do any of the speakers or Stephanie, do you have any other things you want to add in? We're going to have a third webinar coming up, I believe next week. So hope to see all of you there. And thanks again to our speakers for today. Such a valuable session. And you're getting some thank yous in the chat. So that's fantastic. All right, everybody, have a great clinic or a great surgical afternoon. And thanks again for joining us for the webinar series. See you next time.
Thank you for the invite.
Thank you for the invite.
Thank you so much.